Presentation is about patient preference for care and treatment in uveal melanoma. Of interest. As the outline of this presentation, I will define and distinguish patient-reported outcome measures and preference-based measures. I will focus on PROMs, explaining why collect information on PROMs, how to select and interpret PROMs, and what are current results from these measures in the context of uveal melanoma. And I will end this presentation by presenting two studies performed at Institut Curie in the context of metastatic uveal melanoma. What are PROMs, patient-reported outcome measures? The definition is that these are measures of health outcomes directly reported by the patient who experienced it, in contrast to health outcomes that are reported by someone else. This is a definition provided by Patrick published in Value in Health in 2007. These outcomes are specifically important for subjective experiences such as pain, fatigue, nausea, distress, health-related quality of life, and they often refer to frameworks like the one developed by Wilson and Cleary in the JAMA in 1995, which depicts overall quality of life as depending on patients' overall general health perception, functional status, symptoms, biological function, which affect all these, and all these aspects are influenced by the individual characteristics such as his expectations, motivation, personality, coping, and the characteristic of the environment, like the social support or especially the medical care the patient received. Measures in contrast, are measures of value combining a length of life and self-reported health-related quality of life. These are the QALYs, which are used in cost-utility analysis, and the instruments developed for this are, for example, the Eurocall 5D, which is a generic measures for any type of disease, and the ERTC quality of life utility C10Ds, which has been developed specifically for cancer as a translation of the ERTC quality of life C30. Are the same word, but with different meaning in this different domain. For example, in the context of psychometrics, why we develop and validate instruments, these preferences refer to aspects of health-related quality of life that are perceived as relevant, important, and as are prioritized by patients. In contrast, in the context of health economics, preference refer to the value given to specific medical intervention or service, and these are used to evaluate which treatment is better than another. PROMs, and these are the measures have been developed especially because it was shown that clinicians often underestimate or their evaluation are not concordant with patient's own evaluation. This has been shown by Bash and its team in 2009 with measures like fatigue, nausea, pain, which show systematic underestimation by a clinician. So it's important to have this instrument to clarify treatment efficacy and effectiveness in clinical practice, in clinical trials, and also to monitor symptoms and needs by patient in routine practice, and to use these data for treatment decision making. For health policy, these measures are used to perform cost-utility analysis, as said previously. Using prompts in the uveal melanoma treatment, we using the EORTC quality of life questionnaire UP30, it was shown in the large cohort study by D'Amato in 2018 that poor overall health-related quality of life might result from factors predisposing to treatment selection, like being older, more advanced, in a more advanced disease, having poor prognosis, rather than the choice of the treatment in itself. However, a specific aspect of quality of life could be affected differently depending on the treatment, like a functional problem being more prevalent following enucleation, or visual problem following proton beam therapy. Over time, most common problems are fear of recurrence, vision impairment, problem with body image, and using another type of prompts, the cancer needs survey, it was shown that health information and psychological needs was most important over time. To evaluate this aspect, we need to have well-designed, updated, and validated questionnaire. What does it mean? Validation means that we develop instruments that assess consistently and accurately what it is expected to measure. For example, the figure shown below on the left show an instrument that the first circle show an instrument that is reliable but not valid. The second one is an instrument that is valid but not reliable. And the third one is an instrument that is neither reliable nor valid. And the fourth one is a both valid and reliable instrument. And so to achieve this, we need to um, uh, evidence data, that data from the empirical data, that the instrument is valid and as these different psychometric properties listed in the Cosmin checklist. It is important to use these instruments validly that have been valid um, in studies to provide valid data. Um, when we have this valid instrument, we then need to know how to interpret data. And a number of studies are undertaken within the EORTC quality of life group to show how we can interpret data that are collected from prompts. For example, while defining minimal important difference in scores on these instruments, or to identify threshold for clinical importance, or compare data with reference value. RTC QLQ UP30 has been developed in 2004, a long time ago, so it needs now to be updated. And this is the work that I have undertaken with Bernard Osler from Innsbruck University. And we the guidelines of the EORTC, which is follow a four-step process. The first one is to identify relevant aspects to evaluate. And so we first perform a literature review, then interviews with healthcare providers and patients from the target population. And we perform this in at least 4 countries from 3 European or non-European language culture. We then translate the issues into questions and response scale, then pilot this instrument, and in the last phase, we undertake a large-scale psychometric validation, cross-cultural validation, prospective study. We need to ensure the content validity of the questionnaire, so the preference priority of assessment. For example, social isolation, fear of cancer recurrence, progression, lack of information understanding may be issues that are specific to may be important for uveal melanoma patients. And for metastatic uveal melanoma patients, immune therapy side effects may be important issues to assess using PROMS. Prognostication and information wish. These are new opportunities in uveal melanoma, and it is shown that 90% of these patients want information at diagnosis. However, in a study in Germany showed that 36% of the patients decided to obtain this information. And this wish was related to having at enucleation, having higher distress, risk perception, and lower social support. In the UK, it was shown that poor prognosis initially was related to elevated distress, but this was not different from the population norms. And in a qualitative study, Brown showed that most patients do not consider the 50% possibility of poor prognosis. So this may reflect an optimistic bias that patient has as well as the population has. Metastatic uveal melanoma, there are a few studies performed with using PROMs, and these PROMs are generic measures. The first one performed in 2016 showed that 42% of the patient required dose modification due to toxicity, but there were no improvement in fatigue and health-related quality of life over the course of the treatment. Another study in the US show also the need for dose modification and no improvement in quality of life, and toxicities and related quality of life were correlated. Last study showed that more than 30% had borderline anxiety and decreased quality of life, and this was higher for less duration of illness. Two studies performed in Institut Curie, we assessed patient preference for information about prognosis and treatment. We addressed this in consecutive patients, including 50% with metastatic uveal melanoma referred to an oncology consultation at Institut Curie, where the diagnosis of disease progression was made less than 3 months before. And so when asking how important it is for you to know about your prognosis, most patients said that it was very important, extremely important, and there was no difference by gender, education level, or comparing this patient with metastatic breast cancer, luminal B and triple negative breast cancer. Whereas when asked what is the primary goal of your treatment, most of these patients said that it was to cure my cancer, and there was difference in terms of gender, education, and most patients affected with metastatic uveal melanoma thought that it was to cure my cancer. To present here is the study performed by Professor Dr. Sophie Piper-Neumann. It is a study which aims to determine whether the early introduction of supportive care demonstrates a benefit on patients' psychological needs at 6 months after randomization versus oncological standard care. 162 patients have been enrolled from July to February in 2 French cancer centers, and we are now analyzing these data. Uveal melanoma have a specific burden on quality of life, and we have limited information on PROMs in relation to prognostication and increased MRI surveillance. And also following immunotherapy for treatment or prevention. And so we need to update the 2004 AURTC quality of life of 30 in order to address this very important point. Thank you.